Okay. All right, everybody. Good morning, good afternoon, or good evening, depending on where you're joining us from. I'm Elizabeth Ashbourne, PQMD's Executive Director, and on behalf of our entire team, I want to warmly welcome you to today's PQMD Pillar Talk Beyond Hype, the Digital Mental Health Debate. This session is part of our ongoing Pillar Talk series, where we bring together global change makers to explore critical challenges and leading edge solutions in global health and humanitarian response. For those of you who are new to PQMD, we are a global alliance of non-governmental organizations and healthcare companies working to ensure sustainable access to quality medicines, medical devices, and health services, especially for those living in underserved communities or affected by crisis. Our work spans 6 pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, guidelines, knowledge and innovation, and climate and health. You can find more information and resources in the chat. And before we start, just a few housekeeping notes. As Victoria just mentioned, please introduce yourself in the chat with your name and organization so we know who's in the room. Also, please stay muted unless you're invited to speak, but feel free to share comments or questions in the chat at any time during the session. And today's session is being recorded and will be available later this week, probably tomorrow, on PQMD's Community of Practice. Now, in today's conversation, in recent years, digital mental health solutions from mobile apps to AI-powered tools have seen rapid growth, especially in the context of global mental health challenges. These technologies offer incredible promise for expanding access and equity in care, but they also raise difficult questions about evidence, ethics, equity, and scale. Our conversation today brings together 3 global leaders who are helping to shape the future of this field. They bring expertise across research, policy, and practice, and they're not afraid to ask the tough questions about what's working, what's not, and what needs to happen next. So now I'm delighted to introduce our moderator, Professor Xanthi Hunt. Xanthi is a mental health lead at the Africa Health Research Institute, where she leads work on adolescent mental health and digital interventions. She also holds appointments at Stellenbosch University and the South African Medical Research Council, and brings deep experience and expertise at the intersection of mental.
Thank you so much. Thank you for that introduction, and thank you again to everyone for joining this session. I think it's just an incredibly exciting time to be talking about this. It's always been topical, and I think it's very unusual in global mental health for something to remain a hot topic, something that we're grappling with and thinking about for such a long time. And I'm just really excited we are able to bring together a great group of people today, both as the audience and our 2 incredible speakers. I think what's really exciting about being able to speak about sort of digital mental health, but with a focus on apps, AI-driven tools, and sort of machine learning approaches in this space, is that probably about 10 or 15 years ago, we saw this kind of explosion in enthusiasm, particularly in global mental health, but I think really all over the world, in thinking about what these apps might mean for bridging the barriers to care that we know are so acute, particularly amongst our most kind of under-resourced populations. We're excited about what they might mean and how we might apply them with young people, with marginalized groups, with everyday users. And then I think very quickly on the back of that enthusiasm came just a host of implementation challenges and ethical questions, and just a real depth of complexity that the field has kind of risen to meet in really exciting and innovative ways. And so I think that now a lot of the questions that we'll be hearing more about today, and kind of grappling with, are on the back of some of that high and that low, and now reaching a place where we can really think sustainably and going into the future, what is it going to look like to do digital mental health and to do it well, and to kind of deal with questions of evidence, to think about how these solutions reflect complexity and culture, and issues of equity, and then also to think about how we can take the findings from research and from the fields that have been really concerned with this for a while and apply them so that they last at scale and have impact. And it's really exciting that this session brings together leading voices, both in terms of expertise in the kind of funding and policy landscape, and then also in terms of implementation. So I'm very excited for a rich discussion today. I'd love to move now to introducing our panelists. We're lucky that we have Paul Spencer, who is the head of mental health policy at Wellcome. And we have Dr. John Torres, who is the director of digital psychiatry at Beth Israel Medical Center and also an associate professor of psychiatry at Harvard Medical School. We're very lucky that their full bios are going to be put in the chat so that they are long, comprehensive, and incredibly incredible in the depth of expertise that they bring to this. So please look over those when you have a moment. But I'll also ask that in their first responses, Paul and John, you just orient the audience a little bit to where you're coming from. And with that, I'd really like to start with Paul, perhaps. This is a very topical conversation for a variety of reasons, and I think it would be great if you could maybe set the stage for what we're going to be talking about today in relation to some of the kind of big moments that are coming in today's sort of policy landscape.
Thank you, Santhi, and it's really nice to be here. Thank you very much for having me. So Wellcome, for those who don't know, is an organisation based out of London, which is where we are, and we have amongst one of our three kind of health-based missions, we have one on mental health, and we are looking to create a step change in early intervention for anxiety, depression, and psychosis. And we do this by funding research which can tell us about how mental health problems develop and resolve, as well as research into promising new interventions. And then from that, we try and turn this research into equitable action through partnerships and policy work. And that's the kind of angle I come at this discussion today. And as Anthony says, we're a couple of weeks away from United Nations Global Assembly, General Assembly. And within that, there's a high-level meeting on NCDs and mental health, which is significant because it's the first time that mental health's really been kind of pulled out as separate from NCDs, which feels like a significant moment because many of the challenges we face in mental health, although overlapping with NCDs, are distinct. And I thought it might just be worth framing within the context of that a couple of key stats that we found out recently from the WHO Mental Health Atlas, which was published last week, just to underline the scale of demand. So we have 1 billion people living with a mental health problem globally. There's 12 billion productive days lost to depression and anxiety, which is at a cost of about $1 trillion per year. And 1.4% or less of health budgets in low middle income countries on average are allocated to mental health, leaving a global funding gap of about 200 billion. And we know this is a problem, as I'm sure you all do, because we still have 71% of people with psychosis not receiving mental health services. We have limited access to psychological interventions and pharmacological interventions, particularly in low-income countries. And basically, we are a part of a global mental health community who have been trying to shape the high-level meeting, which concludes with a political declaration. And within that, we are expecting commitments that will commit to providing mental health support for tens of millions more people over the next 4 years, and to do that by increasing access to essential medicines, use of digital tools, and community-based support. So in the context of today, I just thought the scale that we are dealing with and the gaps that still exist lend themselves really to this discussion on digital mental health. And we know that there's immense potential in scaling digital mental health to meet the kind of gap in demand. But as we know that there are challenges that we need to overcome. So I hope that's helpful in just sort of setting the scene.
Thank you. I think it is, and I think it's a really nice segue also into kind of the first, I guess, line of questioning that I'd like to bring up today. Because I think for many of those who are listening, and for many of us who kind of come to this field from different backgrounds, it would be really useful to understand against this background of the kind of political context, recognizing the importance of mental health, the socioeconomic context of knowing that there are these significant barriers to care. I wonder, John, if you could maybe set the scene for us a little bit. I think you have an incredible bird's eye view of the field, given your editorial roles and your own work. So if you could highlight maybe some of the kind of across clinical and research settings, where are we currently seeing, particularly maybe LLM-based tools and your more kind of AI digital applications, where are we seeing these being applied and how?
Yeah, no, thank you, Xanthi. And I think I'll start by saying I'm an associate professor at Harvard Medical School, and I lead our division of digital psychiatry at one of the hospitals, Beth Israel Deaconess Medical Center. And I'm fortunate that my background was in electrical engineering, computer science. I don't practice anymore. I don't have a company, but I'm able to bridge both the technology world and in being a practicing psychiatrist as well to see both of them. And I think to set the stage is we've clearly had technology for a long time. There was an era where some of you may not believe it, we would mail CD-ROMs to people or floppy disks you could get a therapy program on. When dial-up internet came, you could get dial-up CBT. We had faster internet, you could get better online CBT. There were smartphone apps, they still exist. And then of course there's AI and there's new technology. So we've always seen mental health move quickly. With technology, clearly AI is a very different technology that we'll talk about. But I think what we've been trying to do, especially in the context of all of you listening, is really expand who we can reach. We know we will not be able to train enough providers. That's a well-known stat. We don't have to go into it. It doesn't really matter what country you're in. I'm calling you from the United States. We're still a low middle income country when it comes to access to mental health. Everyone is in the exact same boat. And so everyone has looked again since we first had computers and floppy disks. I'll go backwards that far to date myself, to can technology help to augment and extend the access of mental health? And I think we've seen some successes in the past. We've seen some challenges, and I think those are going to be very useful for how we shape what we do with AI and what we do not want to do with AI, because again, this is new. And my last statistic I'll cite is, I think it was in the 1960s, the first mental health chatbot came out called Eliza. You can look it up on the internet or ask Eliza about itself. But again, it's intuitively not a new technology. And there is a reason why mental health chatbots in the 1960s did not carry on.
I think that's really helpful. I think it's also useful for you to highlight this idea of there being a continuum in the kind of, I guess, sophistication of the technologies we're talking about, because I think we often speak about digital health or mental health in online applications in a kind of umbrella way, and actually it's quite useful to think about the nuance between these different applications. You also highlight something really interesting, which I'd like to maybe kind of bounce back and to Paul. John raises this idea that we're learning from quite recent history, and that there's this recent history of kind of digital applications, and we know we did some things wrong. And so I wonder, with the kind of equity lens that I know the Wellcome Trust brings to their grant making and their partnerships, is there a risk of repeating kind of old patterns in terms of inequities? If one of the kind of pieces of promise is in terms of access, how might we be able to do things a little bit differently?
Yeah, thank you. I think the answer is probably a bit of yes and no. I mean, we kind of know that innovation reaches those who are most connected, and obviously, when you're talking about digital, most people in the world now have a smartphone, but they don't necessarily have stable data, and not everyone is digitally literate. So, and poor connectivity is kind of rife. So I guess, in that sense, there is a chance to kind of replicate inequity. And certainly in terms of funding as well, I think what we're seeing is a large proportion of the money that's going into digital mental health is going in to global northern countries and to apps and tools developed in global northern countries. And until recently, we've had problems with LLMs not being proficient in languages that are not English. And still, I think the data shows that there's a significant drop off when you're using LLMs in a language other than English. So in that sense, we do risk kind of compounding inequalities. But I think there is also an opportunity here in that the technology itself isn't limited to high-income countries, and there's a lot of innovation happening at more of a pace than, say, drug development, which is very high in R&D costs and typically is coming from global north countries. And we know already that a lot of young people globally are using ChatGPT as a personal therapist. So in a way, the genie's out of the bottle already. So what I think we really need to do now is more focus on how we democratize the elements and how we can ensure that that you can guarantee kind of safety and quality, to kind of take advantage of that thing that John was talking about. It's far more scalable to train an algorithm than a person. So I think basically there's a job for policymakers, and various mechanisms to put in place to make sure things are safe and effective and contextually relevant, and that should all be underpinned by kind of co-design, integration, and kind of a ground-up approach. So I think it's a bit of both, really. We can go quite far quite quickly, but we may not do that safely, and that seems to be the kind of the bit that we need to kind of pay most attention to, I would say.
I think that's really helpful. John, is there something you want to add?
I would echo on the digital literacy part. I think there's a rule in the computer science world or engineering called Moore's Law. And the idea is basically these semiconductors and computers just get double in speed. And it just keeps getting better and better. And somehow the technology engineering world is making smartphones faster, better, cheaper. And I think if we assume that that trend is going to continue, even if you're calling from a country where not everyone has a smartphone, it may be in 3 years they do, or in 2 years they do. And that there's an industry that will solve that. What they won't solve for is the digital literacy to make sure that everyone knows how to use these phones and tools more than just for communication, for mental health. And I think that in small investment in digital literacy really may open up this whole world of tools we're all going to talk about. So I think that the intangible part of digital access to literacy may be the new barrier beyond. Again, some people won't have phones, but I think we can overcome that. What we also noticed in the mental health app world is we curated a database called mindapps.org. It indexes all these mental health apps. It's supported by an Argosy Foundation. There's no commercial interest, but there's a lot of mental health apps. You could argue there's too many. And we recently did a review of looking at, well, what about transdiagnostic apps? Do you really need a specialized app for this one condition, for this one population? It's not harmful, but we found that transdiagnostic apps work overall just as well. So what if you had a fewer tools, but they covered more people? That could be a way that, again, investments in donation philanthropy doesn't go towards building tools. It goes towards building use of those tools and evidence for those tools. That said, there's a lot of apps out there. So if you find a good one, it's not a bad thing either.
I think that's really helpful. And I think that you're both highlighting some kind of interesting things. I think that there are these maybe less tangible questions and promises, right, around access, and then the kind of shadow of that access and some concrete actions, I think, Paul, that you spoke about how that might be addressed going forward. But you also mentioned safety, and I want to come back to that because I think it is also something I think potentially that MindApps looks at is the evidence undergirding these different interventions. And so I wonder, John, if you could kind of, staying with this theme, expand it a little bit away from the maybe more subtle harms of just not being able to access things, or there are too many of them, to speak about some of the kind of pointy edges, maybe. I know that you've tracked real world harms in your work. I think it would be useful for the audience to know what those really look like and their scale.
Yeah, I mean, the most obvious harms, right, around safety. So we've looked at, do they actually have a crisis plan or safety plan? And unfortunately, a lot of the apps don't have the best standards for how to reach out for a crisis. And we had a naturalist experiment. In the US, we updated all our crisis hotlines to 988. And so about 2 years ago, so we were able to, again, look at the apps last year and say, well, did they all update the crisis hotline? This would make sense. We have a national number. Only about 20% of them did. And we found several apps downloaded by millions of people that had out-of-date, broken crisis hotlines. So we have a slight issue on safety there. The privacy issues have been concerning because most of these apps, and again, every AI program we'll talk about is classified as a wellness device in terms of medical legal. This may be changing, but when you're using something for wellness purposes, you don't have privacy, doctor-patient confidentiality, psychologist, psychiatrist confidentiality. Your data may show up somewhere else, and it may be in 5 years, your conversation you had to ChatGPT shows up in someone else's conversation. And Sam Altman is even in the news last month. He said, please do not use it as a therapist. I offer you no privacy protections. It's quite striking if, right, the CEO of the company says, I am not offering you privacy. They're not even hiding it. So that's a little bit concerning too. But what we've seen also in the app world, a more subtle harm is I can tell everyone here I have the best CBT app. You say, but do you? And I'd say, yes, I ran it through a randomized controlled trial. You say, it's very impressive, John. That's the highest level of evidence. And you say, well, what did you randomize it against? And I'd say, nothing, a wait list. I asked people to look at a wall in a dark room, and the other group got this amazing CBT app. And the group that got the amazing app felt better. And the group that got nothing, they didn't feel better. And you go, well, John, that's true. That doesn't really tell us how well it works. And unfortunately, we don't have a lot of that higher quality evidence that really tells you as a policymaker, a clinician, a family member, a healthcare purchaser, how well do they really work? So if we ask a simple question, is it better than nothing? That's true. You could also argue that getting a pet is better than nothing. And I'm not here to say everyone should buy a pet, but there's a lot of things that are better than nothing. Walking is better than nothing. If we're going to spend limited mental health dollars, or PQMD is going to help direct philanthropy, we want to make sure it's better than things that are accessible today.
Yeah, I think that's really helpful, and also good kind of food for thought, because obviously what that standard of care is like looks so different in different countries. It's also a question that has kind of specificity to different settings. And I like that idea earlier around the transdiagnostic approaches, because that also increases the return on investment if it attains to multiple and is effective for multiple different conditions. But what I'm also hearing, and I'm sure the audience is hearing, is that there's an incredible amount of complexity in this field, in a busy field, with a lot of different kind of options and opportunities. And I wonder, maybe to Paul, how funders particularly can begin to prioritize tools, can begin to kind of winnow through this abundance, and with whatever lens is relevant.
I think John's face might have given the game away on that one. I think I mean, it's a very noisy landscape, isn't it? And there are so many apps, and I mean, we've just put in place a particular layer of regulation in the UK to kind of regulate mental health digital devices, but it's a very rare thing. So where there are kind of few standards in place and limited evidence, as John was saying, I think it's very difficult, to be honest with you. One of the things that Wellcome has done is be part of setting up Coalition for Mental Health Investment, which is fairly nascent so far, but the idea is to try and channel more money into mental health, but from our perspective, to do it in a way that makes better use of the evidence and to inform that investment, because particularly in the digital space, there's billions of pounds going in the West Coast of the US into scaling largely the same kind of app, and on a kind of limited evidence base. And actually, from what we see as a funder of scientific research, there are actually promising areas that could benefit with more investment, and there are promising tools that no one is using. So in that sense, we are trying to play our limited part in how we kind of try and inform some of that investment. So it's hard to give definitive advice. I guess prioritizing tools that have independent evaluations, hopefully not RCT'd against looking at a wall, real world testing, I guess, particularly in low resource settings, and transparent data and safety protocols. I guess a lot of what John's done through Mind Apps, and also to say that there are some very well evidenced and used digital apps that WHO, UNICEF, and Save the Children and others have developed and are using at low cost and trying to take to scale. So there are some opportunities there. I think though, just finally to say, as a funder, that there is a responsibility to drive accountability in this space. So requiring benchmarks and evidence for what you decide to fund is really important. And I know that's not easy when you don't necessarily come to a field with an expertise in mental health, and it's hard. I think what we're seeing increasingly is it's hard to kind of guarantee return on investment for a lot of these things. But particularly if you're an impact investor or philanthropy looking to put money in, there are some ways you can begin to kind of find a signal from the noise.
I think it raises some questions too, and I think that your answer is very comprehensive and I think useful in kind of orienting people to some of the indices by which they can make this decision, be it kind of return on investment versus scale, etc. And I think that one of the things that we touched on really briefly at the beginning, and I'd like to bring up again now, is this idea of scale. Is this thing that I raised at the beginning, is that so much of the enthusiasm for digital interventions, and particularly now, I think for ones that are at the higher end of sophistications or require less human input, less support, is in under-resourced settings, because the greatest gaps that exist currently are in those settings. But I wonder, and maybe John, you could kind of respond to this, is if we look at the evidence as it exists now and we think about barriers to scale, and particularly maybe scale in under-resourced settings, what do these look like? And if there are any kind of approaches that are being used to meet these challenges.
Yeah. I think that one thing that we got wrong around scale and mental health apps that certainly applies to the newest things we'll talk about in AI is clearly the technology itself can scale. We said almost everyone will have a phone this year or next year. Who wants one? But that means there's opportunity to access the technology. I think what we really need to know is then how do people engage with it really becomes a scalability issue from a mental health and clinical point of view. And we know in the early days of apps, we went back a decade ago and asked people, do you want to use an app to improve your mental health? 90% of people would say, yes, I do want to use an app to improve your mental health. And we say, that's fantastic. And then 2 years later, we say, have you used a mental health app to use your mental health? And about 40% would say yes. And we said, that's fantastic. Then we said, did you use it for more than 2 days? And about 5% of people said yes. So the point is, we know there's interest, there's potential, and that's good. We need to celebrate it, especially move to AI. But just because it's accessible and people are interested, are we creating the support they need to use it on an ongoing basis? You don't have to use a program or app for life, but it's like if you give someone a gym membership and they never go or they go once, you're not going to have the impact on improving physical health. So I think we have to think beyond just that. Yes, the technology is accessible. Satellite can beam down an AI therapy program to anyone in the world who has a smartphone. I would argue we could do it, but what are we going to do to scaffold the support for that person to use it and get a meaningful change? And we never in the app space were able to build a definition of engagement. I know that sounds fundamental and childish, but we never actually, if you ask 10 people, how do you define successful engagement with a mental health app? Is it times you logged in, number of modules you did, minutes you spent on it, subjective changes? We never got a unified measure of engagement. And because of that, the field kind of fragmented. It was hard to say, what is engagement actually doing? And I hope that we don't repeat that same mistake as we kind of look at our new exciting technologies around the corner.
As a follow-up, are there any, and I mean this to you or to Paul, are there any early signals or existing signals about subpopulations or particular types of people who are more engaged, or particular measures that can be put in place to improve engagement by any of these kind of various definitions that have been used? Because I think one of the things that what you're saying highlights is that there may be that 5% who are using it more than once. What characterizes them? Why are they more interested, more able to? And I wonder if there's any evidence on that.
I'll quickly jump in. It's not what we expect. It's not that younger people are always the higher engagers. If anything, younger people get more notifications per day and they use technology so much, they're less excited. It's sometimes older adults we've seen. It's actually patients with schizophrenia and psychosis who may be more isolated and spend more time on their phones. So I would challenge everyone to not make an assumption of who these current active users are. It's not going to be your kind of college student teen, that they may be your most difficult one to engage, even though on the surface you'd say, well, they're our tech literate savvy person. I think it's going to be one of the surprises that it's the people with more severe mental illnesses, it's the people that may be older, may become the ones leading the charge of how this works.
I think that it's an interesting point. I think it also then it kind of speaks to who these apps are being designed for versus who they may ultimately end up serving. I wonder again, maybe Paul, from the perspective of looking at this in like a field building lens, and have you seen any good practices or the things that you can think about around including either underserved? I mean, historically, for instance, older populations, people with more impairing conditions might be characterized as underserved, but are there models, you mentioned maybe co-design earlier, that are used to ensure that maybe the groups that end up actually using these are included from the start?
Yeah, and I think actually this is a really important place where I guess the NGOs on the call might have a really important role, because I think there's two ways you can go about this, right? You can design for a kind of global problem or to fix a diagnosis or a set of criteria that come out of a manual or a piece of research, or there's this and maybe there's a compromise here because of the transdiagnostic work that John was talking about earlier. But actually, if you design something from the needs of the end users, I mean, this feels like a very simple thing to say, but you will get something that probably meets the needs of the end users. And I think that I can't point to necessarily exceptional practice in the digital space. I'm sure it exists. I know that that some people who want to kind of take things to scale, but also retain that kind of uniqueness that certain populations need. So specific contexts in certain areas, or specific contexts that certain communities bring to, or that bring to their kind of conception of their mental health, is things where you develop 60, 70, 80% of an intervention, and then you have modules that are flexible, which are the kind of the content that is more around culture and language and fit. But the kind of engine of your app or your device is kind of trying to meet the I guess the clinical need, and you kind of put the wrapper around it. But I guess that's kind of retrofitting in a way. And I think what might be important as we go forward is for the INGOs and those who are, I guess, most likely to be working with specific populations, to sort of really begin to kind of set the cultural norms of how we should develop apps. And I think in doing that, we can, as a community, kind of set expectations for what good looks like, and feed that back, so that when we're kind of creating these monolithic things at the other end of it, we can at least embed some good practice. I just wanted to just make one more point, if that's okay, just referring to the kind of this idea, and I think it might be relevant to, again, to some of the NGOs on the calls, this idea that we are kind of, I think we're at risk of separating out mental health, digital mental health, as being divorced from health systems. And it kind of points to John's point earlier around having places you can refer onto and having crisis pathways built in. And one of the things that I see as a kind of risk is that we are still kind of layer digital mental health tools on top of fragile health systems. And a way of kind of circumventing that, again, is, I think, to start from the bottom up and from the needs of a population, so that what you're developing is more kind of in line with the provision that you have. Just thought I'd throw that in there.
It's nice, Paul, to build off what you said is, there's no theoretical reason. Let's just use cognitive behavioral therapy, which is popular at this time in history. If we have new technologies, new ways to reach people, new interests in self-help treatments, there's no terrific reason why CBT, or cognitive behavioral therapy, should become the best way to use technology to help people in different regions and cultures. So I think perhaps one challenge that a lot of funders have is, you do have a new way to reinvent what therapy or therapeutic processes look like. Why take these amazing machines and say you have to try to be exactly like we were in the 1980s? Your goal is to replicate it exactly. That may work, but you could say, well, what if it did something very different? And there's, again, a lot of risk. It's kind of a blue sky research project. And again, as funders, it's very risky to do that because the chance of success may be lower, but the reward would be fantastic if you say, well, what is the best way people could use machines, lived experience, co-creation together, and what does it look like? But as you said, Paul, if you can give people these building blocks, maybe people put them together in really exciting ways that we've never thought of, and giving them the blocks is a little bit less risky per se, but I think it's time to let other people assemble them.
I think that's a very interesting point, and I think it's possibly a replication of like an older tension in the field with intervention development, which is kind of on the one hand things that are built to be universal, and then to kind of maybe kind of gutted and adapted for a specific context. So that idea that you mentioned, Paul, is something that's 80% baked or 70% baked and then adaptable. And then on the other hand, this idea of doing things that are really true to context, really place-based. But I think what you're kind of getting at, John, is something a little bit different, which is this idea of building again from the ground up and seeing what emerges. And I think one of the ways that might be interesting is also in relation to language. So you mentioned earlier around this kind of loss of effectiveness. And so is that, and I suppose that's one of the questions, is when it comes to language and improving the effectiveness of these tools in different languages, is that what it takes? Is it a matter of allowing tools to learn again, using new languages? I think it'd be really interesting if you could speak to that a little bit.
Yeah, I think that we know. Oh, sorry, my internet paused. I think we know that the tools are very good at language because they read billions of things on the internet. So they're going to become better and better at language. And again, depending on your country, how much they've read in your language, that's going to really tell you there's going to be a linear relationship of how good the tool is for language. They're also beginning to move into the tools can do facial expression recognition pretty well too. There's efforts by both Apple and Google to use language models for sensors. So you have a Fitbit, it can begin to find patterns in the sensor data. So I think that we are already seeing the next generation where it doesn't do language, it also looks at emotions, it looks at sensor data as well. So I think we have to think a little bit ahead of what happens if we now have tools that can do language, but also monitoring. We're closer to those closed loop systems we always would talk about, but never could quite get them to work in that part. So in part, that's where I think that the baseline tools that, again, these companies, I have no stock in any of them, be it ChatGPT and OpenAI, be it the Google version, Gemini, or other ones, but the baseline tools do a lot of good stuff at baseline. Again, how it gets put together for mental health is what you all need to think about. But I guess what I'm saying is you may not need to even buy or invest in a company that puts a wrapper around it and they do their training, but it may just be that I think an investment of using those basic tools today to meet your culture, your context, your needs, you could quickly grow a homegrown solution. And making an AI do stuff is getting easy. You can actually ask the AI, how do I make you do these things? It's kind of meta, but it'll guide you, and you do not need to have an engineering degree like me. You don't need, you can quickly pick it up. So I think that the dollars in some ways could go very far. Again, there's still safety concerns. We're not saying these are ready to go. I'm not saying these are ready for clinical care at all. But my gosh, in a research world, you can go pretty far pretty quickly, and it gets better every month.
So I think that's a useful point to kind of maybe circle back to some of the maybe the decision points that listeners will be interested in. Is on the one hand, there are these opportunities, these clear opportunities to innovate in this space, and I think it's interesting to kind of sit with those on the one hand. I've noticed that we have a lot of people who've joined us from NGOs. And so I also think, on the other hand, there are people who might want to be implementing something in the next month, in the next quarter, and in the next year. And there is this idea of, we spoke a little bit about mind apps, but benchmarking is an issue. So how do people who are wanting to do work with this, who may not be in a position to innovate or to do something differently, make sense in the absence of kind of a coherent evaluation framework, decide if a tool is safe, is appropriate for use? Like, what are the kind of concrete steps that people might take? And this is to either of you, whoever would like to take a first pass.
Ah,
The hard ones, Anthony. I'll let Paul go first. Give him the hard question.
She wouldn't have done that. In honesty, I don't know. I think I don't know, but I would say that if you're working in a local context, your local context is key, and that will give you a lot of feedback, I guess, about what is acceptable. But it's hard to know how you guarantee sort of quality. I mean, there are benchmarks out there that are being developed all the time, and I think but we need a kind of a standard that we can all agree on, and that we can use as either a guarantee of safety and quality, or a proxy where you can't put in place sort of further legislation that might guarantee a medical device, for example. So I've not answered your question, and I have given John enough time to answer the question in my place.
It's we've been also, I mean, everyone's thinking about how to evaluate AI. And so we went to the mindapps.org database that's in the link, and we said, well, could we just rate AI based on the questions we have for mental health apps? And we said, some of them apply, like, is it private? Who is it owned by? Things you want to know. But then we said, it's really tricky because in AI, you can ask it, anything can come into it, right? Infinite things, and it can produce infinite outputs. So it's really hard to have kind of a checklist and say you've covered all infinite inputs and infinite outputs. Infinity times infinity is still infinity. So what we are thinking of is, we said, well, we can't cover all the things, but AI can quickly answer a lot of questions, right? That's what it's good at. You can give it a script and say, answer 10,000 questions, and it'll probably do it in 10 seconds. So we said, what if we could give it a lot of different cases to solve? And again, it wouldn't just be, what is the best medication to do? What is the best therapy to do? It'd say, well, you have a case and you have 4 options. Do you want to do option A, B, C, or D? And each of them may have some validity. And then you would have clinicians or patients or peers in your region kind of say, what is the current standard of care? What do we do in this option? There's not a wrong answer, right? You can always say we do therapy, we do medications, we wait. But you can imagine that you have your local community vote, you involve them, and then we run the AI every night on those questions and say, the AI update overnight, and now it thinks that the best answer is this. But you can actually then, by having your community create the cases that matter to you, not to me, not to Paul, not to you, Xanthi, and then having your community vote, you can say, this is what we think the best option is. You can see what the machine does. And because we don't know when the companies update the algorithms, we know big ones like ChatGPT-5 comes out, it's different. But each morning you can wake up and say, which AI is most aligned with me or is not most aligned with me? So this is what we're thinking of in benchmarking. And because our team is not clever on naming things, we had Mind Apps for apps. We have Mind Bench AI for the same thing. So we're working on it. We should have a prototype out soon, but again, it's a very simple idea and it's powered by you. We're just asking you to create the questions and to vote on them. We're just going to feed it to the machine and say what it gives back to you. So it really is, there's no special knowledge. It's you bringing what your communities do best and what you feel is best. And we just mirror back what the machine thinks, if it's right or wrong. So I'm hopeful that a community-based approach like that could at least give us some initial insights, and also to enforce the technology companies to do better. Because we say, look, you really don't do well in these questions. Technology companies in some ways like a leaderboard in competition, and this kind of gives them back what they like. So I'm hopeful that we can regain some control, but again, that requires everyone here kind of, again, bringing what are the things that matter, because I don't know those, and no one else knows them except you and the people that you work with.
I think that's one of the nicest discussions and kind of framings of defining harms, actually, and also defining good outputs, because I think that that's a particularly difficult thing to do in relation to this. Like, what does it mean to miss something? What does it mean to give a good response? What does it mean? And I think that's an incredible kind of an innovative approach to doing so. I can see that some questions are trickling into the chat, which is great, and I encourage people to keep adding them. To give people the opportunity to add 1 or 2 more, I'm going to ask you each a kind of final question. And while I'm asking that, if listeners can just add. But I think that maybe for Paul, you've spoken to the kind of the complexity and the urgency and I think the timeliness in relation to the kind of UN meeting. If there was one takeaway that someone could take home with them after this call in terms of kind of scaffolding their thinking about this sector, would you be able to summarize that? Maybe 1 or 2 sentences.
I can have a go. I think probably what the power of the people on the call is that you, as John was saying, you are working with populations who bring the context that we need, and that should become the norm of how we approach these things. So we're kind of at a crossroad. I think we've all acknowledged that, and it's understanding and appreciating the insights that you have, whether you are a digital expert or not. I think you understand the populations, and that really is one of the key things I think we can kind of bring to the table on this. I think from a funding perspective, something that I'm very conscious of, we're doing work on access to psychotropic medication at the moment and trying to see how we could increase that in certain areas. But as with everything in mental health, you can't do something in isolation. So I think understanding that mental health is scalable, more so perhaps than humans are, but that actually you need to do that within a strong and stable health system. So investing in health system building as well as digital, I think is really key to kind of see those things as part of the same package.
I think that's incredibly helpful. Yeah, and a great point to, I think, depart from going forward in thinking about this. And then, John, I think for you, you mentioned something, I've heard you speak about this before, and I think it would just be great to hear a tiny bit more. This idea of digital literacy is kind of the missed opportunity maybe in this landscape to really change things. And so maybe if you could distill for people who are listening, what does that look like in kind of a concrete way in terms of conscientizing different stakeholder groups around this?
I'll put a link in the chat. If people can't access it, email me, I'll send it to you. But this was a survey with New England Journal of Medicine Catalyst. They surveyed about 700 healthcare leaders around the globe, not just the US, and asked people, what is the single greatest barrier to virtual care services, including mental health, but not mental health? And the single greatest barrier was, again, digital literacy of patients, but below it, again, was access to technology. But I think what we're seeing is, right, say in the NHS, there's an NHS app you have to use. A lot of people may be able to use their phone to make a phone call or look up the weather, but you have to be able to use an app, access your account, download the app, troubleshoot the app, log in, change passwords. These are things that all of us, by actually being on this call, are excluded from understanding what it means to not have these skills. So in some ways, I think we're all a little bit invisible to it, but we've shown in other groups too, if it's very easy to teach people the digital skills. The catch is it has to be done in person. You have to actually give people hands-on training. The irony of teaching Zoom through Zoom is lost on nobody, right? But I do think it's actually a very low investment to kind of upskill the digital literacy. And again, you're opening up your whole population to a world of interesting digital tools. I say interesting because we talked about, Paul said some are very good and free, some are perhaps terrifying and not private and dangerous, but helping people make sense of those tools, I think, is a good first move, because then you have a more informed population. And that also may solve your engagement problem, where why do people always download apps and not stick with them? Maybe if they're more able to use it. So I do think it's, I can't promise you an AI or machine learning or large language model for literacy, but I think it's a quick win that could have effects that are impressive downstream.
Thank you. I think that's a nice summary, and yeah, I mean, I think the irony is never lost on us that sometimes the things that either improve engagement or uptake, whatever, are people, despite the sector in which we're working. I'm going to move now to the chat and take you through some questions. These aren't directed to either one of you, so I'm just going to let you kind of respond as makes sense. The first is from Craig Parks, and it's just asking thoughts about building a new AI bot that learns what is effective to the individual to improve their unique well-being and measure their outcomes using measurement-based care assessed over time. So kind of a personalized approach.
It makes a lot of sense. There's a measure in these chatbots called how many parameters it was trained on. You can look this up for ChatGPT, and the number of parameters is kind of the number of data points it had, and it's often now in the billions. I wonder if it's in the trillions for ChatGPT-5. It's not always public, but the point is you're going to need millions of cases to train it very well, or at least tens of thousands of cases. So I think that potential works, but the question is, do you have a data set with tens of thousands of cases, if not millions of cases? And of course, the risk is if you train on only a little bit of data, it's a machine, it'll try really hard to do what you want to do, but that's where it'll fail, it'll be biased. So to really get it to the point of just think how much of Wikipedia, Reddit, and the internet, and books that these things have lawsuits that they now stole and read from publishers illegally, you need that level of data. So these are machines that are wildly data hungry. So if you only have 1,000 cases of outcomes, it'll try hard. But I think what you're getting at, which is a good question, Craig, is what you need a country to agree to do it. So the NHS would have to say, here's the health record of every single person, or Australia would have to say, I don't pick the US because we're too fragmented in how we share electronic data. So possible, but I think it's more a political issue than a technical issue.
Thank you. And please feel free to elaborate on your questions if you have kind of follow-ups. Also in the chat, we have some more time. There's also one from Braden Remington, who's from Direct Relief. So about given the potential for digital mental health tools to amplify care, how are we confronting the reality that in many LMICs, we're still dealing with these basic issues around internet, electricity, and are there examples of solutions that sidestep traditional kind of web-based platforms?
I mean, I think there are, and I can just off the top of my head, maybe we wouldn't call this digital, but there are ways that you can take the content that you would otherwise apply digitally and put it in podcasts and put it in other ways. I think a lot of the way that certainly people like UNICEF and WHO are approaching this is that there is content that they would use in various mediums. One of them might be digital, but then some of them might be in videos on YouTube, some of them might be through podcasts. So there is a way that you can take content which is helpful maybe for, I think, what we might, unfortunately, in this conversation call like mild to moderate symptoms that can be effective in different ways. But yeah, John, you might know more specific tools.
Yeah, it's a tricky one, right? I mean, if you want to use the latest chatbot, you're going to need an internet connection because it runs off a very big computer. But you can still have a rule-based chatbot, right, that says go left or right or that. So what I guess I'm saying is there's a lot of things you can download and put on a very inexpensive phone and then not need an internet connection for. So it could be that, again, people are living in rural areas, the internet's not going to get there yet, but a lot of tools can be put on a phone and you don't need the internet for a long time. Again, you could argue that a rule-based chatbot that kind of follows an algorithm, just because you can do it on a large language model doesn't necessarily mean it's better, right? If you give someone a rocket ship versus taking a car down the street, technically the rocket ship's going to be very confusing to get 10 feet, where the car is going to get you there in 5 minutes. So just because we have these advanced technologies doesn't mean they solve every case, and rule-based chatbots could be a great solution where you download it once and then you never have to connect to the internet again.
I think that's a really good point. Also, in terms of kind of thinking, I know in terms of the way that some governments are approaching this is kind of stratifying resource allocation. So thinking about better connected populations and what might be at a level that is easy to roll out directly there because people have phones, they have connections, and then how you can better allocate more intensive resources, maybe including actual therapists, but also including some of the technologies you're speaking about, which are just as effective, but in a more targeted approach to populations where that is needed. So I think it's also thinking carefully about what's fit for context, which is really useful. Yeah, go ahead.
I mean, we've implicitly focused on AI as a therapist and a treater. There is a world where you say, again, we have more sensors, we have measurement, we can debate the ethics of that if it's good or bad. But it may be that we now can collect so much data about each person's experience of mental health on a sometimes minute by minute scale. We may now have technology eventually, as we said of Christ's question, with enough people to understand it. But it may be that the real revolution is we have a new way to finally understand and categorize mental illnesses. So yes, we call it depression today. But what if we actually could combine your genetics with your fitness data, with your sleep data, with social data, with your self-report symptoms and your medication response to really say, no, that's what we called in 2025 depression. It's really now this condition type 3, 4, and we know exactly what type of therapy and we know exactly what medication targets it. So it could be that not by even going backwards, but by using the power of these new sensors, these new data, we rethink about what a mental illness is and really move more towards a prevention paradigm. So again, there's nothing wrong in trying to make this amazing technology copy what we did in the 1980s. It's a wonderful goal. And we should do that because it'll help some people today. But there is a larger picture of the measurement and computation parts of these tools could really reconceptualize what we think of to the point where in 10 years when people laugh at us for saying, you called that the illness. And that's an exciting potential. I think why all of you guys as, again, funders are really at such an exciting time to have impact, because we couldn't make a statement like that even 5 years ago. These are new. So I think there's a lot of good on technology, both on the monitoring side as well as the therapy side. And we do need both. We can't just wait for new measurements to come along and not help people.
Thank you so much. I think it's an incredible point on which to hand back to Victoria. But before I do, just to say thank you so much, Paul and John. I think you've taken us through this very complex field very quickly, very succinctly, and I think balancing kind of immense depth with issues around access, around, as you say, the CBT on a phone versus these kind of blue sky, and I think really uplifting notes to end on is to just think about the incredible potential that still exists. And so just thank you very much for really rich answers.
Xanthe, you said it so well. I was just going to thank all of you for the exact same thing, especially your leadership through this conversation. It really has been a fascinating discussion, and to everyone who's joined us, really thank you for being part of the PQMD community, and we encourage you to continue the conversation in our community of practice, where the recording will be available.